Good morning, Dennis.
Hey, how you doing, Lynn?
I'm good.
Good.
Good. Amazing how fast the 3 months go, isn't it?
Yeah, I was at the conference. Wow.
It's a thing I want to listen to. Starts at 11. What do I deal with it?
You doing all right?
I'm doing
Good.
really could be glued to the TV set watching until I reach that point where I have to shut it down because it's overwhelming.
Yeah.
Has Robert popped in yet? Have you seen Robert?
I'm not sure who Galaxy A10 is. No.
Are you talking? What? People are saying
One
one.
voting on agreeing to the resolution, and it says
What?
Republican 183 to,
What's the resolution?
I don't know, some kind
Okay, I'm listening to my stuff.
of, okay, well, can we do this today first?
Yes.
Should I get a crown and bundle her up?
I'm not
to have
sure.
her head sticking out?
I'm not sure who's speaking,
Yeah.
now, but I just want you to know that we can hear you.
That's great.
think it's exactly 12 o'clock. And if it's okay with everybody, let's just give one more minute so that people can arrive if they're going to join us. So great to see so many people here. Welcome. If anybody hasn't had a chance to look at the article, you can go on to the member website for Insta and access it there. Okay, I think it's time for us to get started. I am going to ask if everybody can can mute their microphones until you have something that you want to say, of course, put it back on, but I'm getting some feedback. I'm not sure you might as well. My name is Lynch, and I'm really happy to be here today. I am on the editorial board for the Journal of Addictions Nursing and a member of INSTA. And I'm so happy to see so many people here. This is really good news. Some old faces and some repeat customers. Always good to see. Can everybody hear me okay? Yeah, okay, good. Good, thank you for that feedback. The article that we're talking about today is from the most recent Journal of Addictions Nursing, and it's educating nurses on the use of the clinical opiate withdrawal scale to improve care of adult patients undergoing buprenorphine induction by doctors Uga, No, Lynch, and Summers. So this is we've been pretty lucky. We've had, in the past, we've had the authors come and join us and share some of their experiences. And I don't, unfortunately, I wasn't able to reach any of the authors this time. I think it's just a crazy time for people, especially in education, not knowing who's in their office and who isn't. So we're going to talk about the article ourselves, about the advantage of having the inside scoop. And again, if everybody could just turn off their mic until you have something to say. I'm just going to just give a brief review of the article, oh so brief. This was a study that was done out of the University of New Mexico State University. New Mexico State University. And it was a improvement project that was done, I assume, by the DNP students. And what they did was they went to an outpatient source, an outpatient site, and got together, I think it was 13 of the nurses and 2 of the nurse practitioners, and get a training of, I don't know how long it was, but it was a one-time training on the clinical opiate withdrawal scale to improve care of adult patients. Sorry, I'm distracted by something, I apologize. So they did a pretest, then they gave an educational component, and then they measured them immediately after the education, and then 3 months later. 3 surveys. And what they discovered was that with the addition of the training, they saw an improvement in the nurse's ability to monitor withdrawal symptoms, and they felt more positive about the experience and about their ability to communicate. So it's pretty much an educational DNP project that we're talking about here. I found it really interesting, and I'm I've asked 2 people to join specifically because I think they have more experience in Suboxone than I have. This was done in an outpatient setting, and I understand that it was a mental health setting. I don't know that they specifically focused on addictions. That was part of the questions I was hoping to understand. But it does seem like it's an outpatient mental health program, and it went for 3 months. So the 2 people I've asked to join, one is Kathy Fornilli, past president of INSTA, who is referenced in one of the, she's one of the references from a 2010 article that she did. So I thought she might have some experience in Suboxone, even though she's predominantly in education. And yet I think education is one of the main things that comes across to me when I read this article, was the education that we provide or don't provide to students on how to assess patients who are in withdrawal, whether it be for addiction in an inpatient setting withdrawal, or if it's in an outpatient clinic where we're trying to get somebody started on buprenorphine. The other person I was hoping might have some experience, and I'm not sure actually, now that I think about it, Dennis, I wasn't sure if you had worked with buprenorphine in a buprenorphine clinic yourself or not.
Yeah, that's primarily what I did.
That's what-
So I thought the article was good in terms of for a QI project, because I do believe that everybody needs to know how to interpret. I remember when I first started working with buprenorphine, I didn't have a clue what COWS was. And there's such a variety of things in terms, they talk about precipitated withdrawal, which is an important component relating to starting somebody with buprenorphine, but I think knowing what the COWS is important. One thing I did not know or wasn't very familiar with is, this category down here in the COWS about yawning. Why would yawning matter? And then I saw several people that would, be just yawning incessantly. Just they said, "Are you tired?" No, I'm not tired. So I'm sure it's
Part of withdrawal.
probably a part of withdrawal, but I think it's a neurological component. The other thing that is not on here, what I've seen quite frequently, was sneezing. A lot of people said, "Well, I don't yawn, but I sneeze." I thought that was kind of interesting. So
I had
That's not why I sneezed with my mute turned off.
Hi, Kathy. I was surprised, and yet I stopped teaching about 2 years ago. And we did not at that time have an identified course specifically in addictions. So addictions was a very small part of the psych mental health undergraduate. And so I guess I was surprised and yet not surprised that people can leave us a undergraduate program or any program, I suppose, and not really know how to do the COWS on a somebody who was in withdrawal. Kathy, I know you're teaching these days still. Would that be something that you would have expected students to know?
Not really, because not really, because our students only take addiction. They only get about an hour of addictions or a half a day in addictions if they're not in one of our electives. So we've been offering an addictions nursing elective for undergraduates since 2010 at the University of Maryland School of Nursing. And we just started last semester a graduate introduction or foundations of addictions nursing. We have and we include the COWS in both of those courses. some of the one of the assignments in the undergrad course is for students to talk about what they see in their nursing units, because most of them are RN to BSNs. And a few of them are familiar with it, like in emergency departments, but most of them are not. So we include the CALs in both our graduate and undergraduate Introduction to Addictions Nursing course. And I'll just throw out that we have a brand new certificate program, a 12-credit certificate program for addictions nursing that just got approved by the Maryland Higher Education Consortium. So we're now teaching the foundations at the graduate level for the second semester. We're starting a graduate level MI course next week, which we've already had an undergraduate motivational interviewing course. And then there's a special topics in addictions nursing and a advanced clinical practice in addictions nursing with a clinical component for the 4th class if people are enrolled in the certificate program. So thanks for letting me have a shameless commercial for our program.
I think that's great. I'm glad you added it. And I would really like to hear other people who are on the call here talk about their experiences. If you're having experience in an outpatient program, detox, or if you've done any work with Suboxone clinics, I'd love to hear.
Yeah, I have. My name's John. Can you hear me?
I can. Hi, John.
Yeah, I have. I've been. I started the first in Cincinnati. I've been running a methadone clinic for 31 years, but we started one in 2003, 4, and I opened my own, and I've got a methadone and a Suboxone program in Middletown, Ohio. That we have about 160 Suboxone. So we mix them up, and the thing that we're finding is that Suboxone works for some people and methadone works for some people. It's just the way it is. And it seems like that we're seeing a lot of methamphetamine use with Suboxone because they don't really get because it's a partial agonist, it doesn't really get them to where they want to be. They want to get some kind of satiation, what I call it, the come on effect. After about 45 minutes after taking methadone, they drink a hot cup of coffee or whatever, and then they feel a little bit. And even when I've got people that have been here for 28 or 29 years that are doing very well, they get monthly take homes and they work and they move on. But I'm seeing that Suboxone is good for people that are not mired into the opioid, don't have 30, 40 years in, because they typically are the ones that I have the most difficulty with using on top of it, because they want to feel something. And that's the thing that I hear from them mostly. So just wanted to pass that on. But it's interesting. There's I think that every different medication has its thing. We use we use Sublocade, but we also do psychiatric care. I have 2 great mental health psychiatric nurses that I call them my doctors because they are great. They do genocyte. They try to find out whether the chicken or the egg came first and how to fix both of them. So that's my little piece. We also treat opioid addicted moms with both Subutex and with methadone. And I started the moms program in '98 with Dr. Finnegan and Dr. Ballard from UC. So that's it for me. I'm going to get off. I just wanted to come on and see how you guys did. I'm on the board and I wanted to just be supportive of you, of Jan.
Well, John, while you're here, and I'm glad to hear that you're here from the board, from the INSA board, but John, do you use the CALs in your?
Yes, we do. Yes.
And how is that working for you guys?
We use a couple different things because we do an ambulatory stabilization or an ambulatory detox, depending on if their ASAM criteria puts them in a withdrawal. Sometimes they come in withdrawal. Sometimes they come in, very high. So what we do is we have a really nice room with aromatherapy and nice chairs that they can go back and sit in and stuff like that. We do use cows, but we do use other things too. And it's not always a checkoff thing. It's more of a feeling. How are you feeling? You can kind of see how people are reacting because they don't always tell you that they took an opiate that morning and you give them a Suboxone. We try to start them off with Subutex because it doesn't quite get them into a precipitated withdrawal, but we definitely use it. And I try not to let the patient know what we're doing there when we're checking it off until after, because sometimes you ask them how many times they did this, how many times, they sometimes will manufacture that because they think it's going to get them more or things like that.
I have a question, John.
Yes.
Surprised to see that 20 out of 24 of the people that were part of the study, the patients population, 20 out of 24 dropped out. That's I know that the recidivism rate is high, but I didn't realize it would be as high as 83%.
They dropped out.
Yeah.
Yeah. I don't know. You know what? I tend to believe that a lot of the programs that do this don't spend the time. You have to spend an awful lot of time with people that are addicted and that have mental issues. Also, the dual, they used to call it dual diagnosis, and I'm still old school Sammy and things like that. But we spend a lot of time with our patients, and that's why we do have a lot of dropouts, but those are the people that are coming in just to get the medicine so they can sell it and get whatever they like,
Mm-hmm.
So
you do counseling with them as well?
Excuse me?
You do counseling as well? You don't?
Oh, absolutely. We have intensive outpatient. One of our things is that our doctor spends at least 30 minutes with every patient when he visits them, and then they go to their counselor, and we have IOP in the morning and the afternoon. And we don't go 3 hours because it's found out it's too much, but we also feed them in our IOP. So they get a nutritious meal if we try to get them something that's good. But that seems to work. And now with even COVID, my one IOP room seats 50 people. We have a lot of things in there. So we use 12 only in there, and we keep them 10 feet apart. And then the other ones, we do telehealth. We have a really nice telehealth program at my other program. We gave out over, I think, 300 laptops, or not laptops, the pads, so that they could go do it that way. But I still think that face-to-face works better. But
So John, I was wondering, do you think that the cows has been useful to you guys in terms of making sure that people are in withdrawal at the time of their induction on the methadone,
yes,
on the buprenorphine?
Yeah,
and does it prevent precipitous withdrawal in those patients?
Yeah, because I've had people, the hardest thing is to go from methadone to Suboxone. It's very easy to go from Suboxone or buprenorphine, by itself to methadone. I just started with our new methadone program up at my place that I own, and I've changed over 7 people in the last week, and they're all doing better, they say. We'll know by drug screens and things like that. But yeah, you want to make sure, because boy, when they go into that, when they go into withdrawal, they really feel like they've been Narcaned, and they have been Narcaned.
They have.
And so we do count on that, but it's more of, I keep a nurse in there, and every 45 minutes we only allow 3 or 4 people inducted at any given time, and they're spread out. And we watch them very closely. If their blood pressures are going out of whack, and they're starting to have really high pulses and they're sweaty and things like. We start noticing that kind of stuff. But it goes like this. It's so fast they can go right into withdrawal, and then they're mad at you, and that's when they get up and leave. If you don't have comfort meds, we offer comfort meds to them, and then we do have a way that I have a hospital that's very good, an inpatient program that will take them if they really can't make it, we'll send them there. But yeah, you're right. It does help with that. I think CALS is a great tool because but again, you got to be careful how you use it because it can go both ways with it, and you have to have somebody watching them, because how can you find out how many times somebody's yawned if you're not and seeing that and type of thing. But we have most people are come in, they're high when they come in, but a lot of them are high on other things like benzos and methamphetamine and cocaine. So it's not quite as bad, but we've had our share of people getting mad at us because they thought we gave them straight Narcan or something. So
John, I just keep having more questions for you. You say you keep observing them, but do you score the cows multiple times?
Yes. In every 45 minutes for 3 hours, we score it.
Okay.
Even if we're doing a new methadone patient, we do that. They're allowed 30. The federal government allows them 30 milligrams the first day, but if you keep them there for 3 or 4 hours, and you can raise them to 40. And then we usually do a titrate up with methadone or with Suboxone also. We start them off at a low dose of Suboxone, maybe 2 milligrams, and see how they do. And then they may get another 2 milligrams in 45 minutes, depending on what's going on with the cat. We have a neat form, and I'll send it to you sometime. It's got 3 spots for the cows every 45 minutes or every hour. You can do it. And we call it ambulatory stabilization, not detox. Ambulatory detox is when they come in real high, and then we do it the other way with them, So yeah, that's the way it goes. But it's interesting. I didn't think I'd like Suboxone as much as methadone, but we use both, and we also use Vivitrol and the other, you use abstinence. We do anything that'll work for them. But the cows does work for me. I think if you use that, and then you use the CLIA, CWA, and some of the other ones, those scales also are good.
Rachel, I don't know if I could hear Lynn. I saw your lips moving, Lynn, but I don't know what you were saying. I've been a registered nurse since 2012, and my initial experiences was in critical care. But in 2016, I switched to addictions nursing. So my first job was in an outpatient hospital-based clinic that was starting a totally new grant-funded program to integrate opioid use disorder care in an outpatient setting within the primary care setting. So I was tasked with kind of, shaping that program along with the rest of my team. And I had not ever done a CAL scale before then. I had not, to my knowledge, I don't remember, received any education about it. And a lot of my understanding of CALs was either self-instructed or, came from standing on the shoulders of individuals that I trusted that could help me learn about how to do that. But luckily, I was not a brand new nurse, and I was able to find reliable information, but certainly my confidence wasn't there. And it felt very similar to my neuro ICU days, where I would do a scale and then the physician would come in and get a completely different number. So I think I had a lot of fear too around like the interpretation of each item. But luckily, confidence built over time doing that more and more. And also in the outpatient setting, we didn't really have a lot of means for it because we did home inductions rather than office inductions. So we might do a CAL scale just to get a good idea. And there were scenarios where we may have an individual who is struggling with buprenorphine induction and recommend that we try an office induction to help guide them through it and be there with them, kind of as their cheerleaders. But unfortunately, none of the individuals we planned that with, and there were probably around 10 times through the three and a half years I worked there, none of them ever came for that, unfortunately. But we also found that fentanyl and fentanyl analogs very, very much complicated this process and made the cow scale more unreliable because the number didn't indicate readiness to induct always.
That's ridiculous. If I heard
And
if I heard you correctly, you were using that in an outpatient setting, correct? It
That's
wasn't
correct.
a mental health setting. I kind of wonder how that would work, how effective that is if you don't have the counseling piece that goes along.
Did you say counseling piece?
Counseling piece, right? So I work in an outpatient facility, and counseling is sort of what we do.
Mm-hmm.
I wouldn't expect it to be quite as effective unless it had a counseling piece attached to this.
Counseling piece, as far as what's effective, the cow scale or the treatment?
As far as them remaining off the opiates.
Okay. Yeah. So we did have an interdisciplinary model where we had an LCSW and an LSW providing counseling, level of care assessments, and referrals to treatment or higher levels of care when our level of care could not support the individual in their recovery.
When you were talking about the neuro check that you did the first time, I can remember so vividly doing a check for pedal pulses. I think I was my very first job. And I was so nervous, and I thought for sure there was no pedal pulse. So I understand the anxiety. I'm glad that you're competent now and you're comfortable using the cows. And you're still working in the same facility?
I'm not any longer. I've moved to managed care, so I work as an addiction specialist for a Medicaid, Medicare managed care organization.
And do you use the cows there to authorize continued care? Is that part of what you pay attention to?
To my knowledge, there's nothing as far as like medications that would require a pre-auth or things like that. There's nothing to my knowledge in which a cow scale, the number itself is actually necessary, especially because the cow scale is going to be a very in the moment number, and a lot of stuff in insurance and higher up government things move at a much slower pace. So I don't know that, I think that's not included because it's not relevant information at the pace at which we work. But none of my work is actually member facing. So there's nothing I'm doing. I'm not certain, however, if our telephonic case managers or our community-based case managers or community health workers are doing that in their roles.
You'd be surprised, Sal, if you do a SALS with the subject of like you, Rachel, you're like my hero because I want people to know that you can give so much insight into what we're missing. Now, I because I've done it a long time. I said I didn't even start to understand addiction for my first 20 years. Now and I'm just starting to get to understand it. So you can be of great value to nursing because you've been through the fire, and I'm proud of that fact. And these are the type of things that will help. We use a SALS to a subjective opiate withdrawal scale also to kind of mimic, because I'm a harm reduction guy. I tend to truly want to know what that patient feels, even though they may be still in the phase of manipulation. I still want to know, is it working? Are you feeling any better for real? Or do we need to do something different? So that's why I'm glad that you said that about the cows. You can have 3 different people get 3 different numbers.
so I want to add that the cows has more value during the induction than it would at some other point in the counseling process. as I understand it. But I also think that I want to make 2 points. The first is that it can be an educational piece during the induction, so that you can show people that if you're not in withdrawal, a good withdrawal before we start the bup induction, then you're likely to get into precipitous withdrawal. And so you can use these numbers to help them explain to you how they're feeling, and, you know, kind of like teach back using these results. And then the other point that I wanted to make is that we shouldn't just think about this for its utility in drug treatment. We should also think about it in its utility in general medical settings. Like, and I'm not talking about the primary care physicians that are starting patients on buprenorphine. I'm talking about emergency departments and ICU settings. And so we're finding in the work that I did with Virginia Commonwealth University around buprenorphine or around substance use disorders, and from what I know at some of the University of Maryland hospitals where we started buprenorphine inductions in an emergency department in a small satellite hospital. I think that in the DMP project where we did that, they only identified 32 candidates for the rapid induction, rapid transfer from the ED to IOP clinic where they could get their induction done. And of those 32 people, they were excluded because they had a medical condition that required a transfer to a medical unit before they got their bup induction. So the part of the DMP students project that really sustained itself in the emergency department was that the nurses and doctors in the emergency department were keen on using the CALs after they had started doing the CALs to recruit people to the buprenorphine project. Now we can, we've also begun training the med surg floors to do the CALs, because they're, you know, opioid using when they came to the ER, but they had to go to the medical surgical unit. And from what I know at the trauma unit, you know, University of Maryland has a level 1 trauma unit, and Virginia Commonwealth University as well. They both were aware of the fact that unconscious or sedated ventilator patients, surgical patients, anesthetized patients will go into withdrawal, and they didn't even know they had an opioid problem. So I think using the objective CAL scale helps them identify some symptoms of withdrawal that might have otherwise gone unobserved because of the patient's inability to provide a history of opioid use even before the tox screen comes back. So I'm really interested in how they're using it in other settings besides drug treatment.
That's a great point, Kathy, and it
Thank
really
you.
changes how you think about education. It's no longer just in an addictions class or even in a psych class, right? This is a much more broad application.
Because as a part of the magnet status at VCU, we did focus groups with nurses, and all of the nurses in every setting and every specialty were perplexed by what to do with substance using patients, how to identify them, how to manage their withdrawal, how to treat their pain, and how to refer them to community-based resources. But the ones in critical care, surgical, neurotrauma, all of those people were really concerned about patients going into withdrawal while anesthetized or unconscious. And that just really causes their patients to tank if you can't even identify that this is a withdrawal thing and not a cardiac neuro kind of thing.
It seems like Maryland is so far ahead of other states, because you guys did the buprenorphine study, I don't know, maybe 10 years ago, that where you guys were using up to 32 milligrams, and Ohio went into this, oh Lord, we got to keep them at 16 milligrams, and things like that. So I look at, and I really think that that makes a difference in what state you're in on how people are also treated in addiction with.
And John, that goes with prevalence of opioid problems too, because University of Maryland Hospitals is in Baltimore, which is the overdose capital of the country pretty much. And so the more you deal with those problems, the more familiar you are with addressing them. And if you're in a smaller city that doesn't have as much of it, you don't see those patients as often, and you haven't seen what works and what doesn't work with those patients.
One of the things that I remember from working in the clinic in terms of using the cows, it was good. A lot of my docs, they just kind of went on the pupillary response piece before they would induct them, no matter what the cow score was. But in terms of using it, some people, use up their medications, or somebody mentioned before, selling it. So they may run out early in coming in and trying to decide. The other thing is new starts. It's kind of difficult to tell because buprenorphine's on the street. A lot of these people have been exposed to it before, and they know that they're going to be, if they're going to start buprenorphine, that they don't need to be in withdrawal, because they've probably experienced precipitated withdrawal on the street themselves. I do tend to agree with John that a lot of the people are getting into the methamphetamines a lot, which I think is another big problem that we're going to need to look at overall in the addiction stage, because using a harm reduction model, yeah, well, we're going to keep people alive, but we're not addressing the addiction issue pertaining to marijuana or alcohol or amphetamines or benzos, and those are kind of areas I think that's necessary. I also wanted to ask a question. How many people use the Sublocade? In terms of, I used it rarely. Before I left, we had like 5 people on it. And part of the rationale for doing that was these people would go out and use on top of it. I've got one guy that knows how much morphine that he has to inject in order to overcome the buprenorphine block. So a lot of these people are looking at trying to, still trying to get high, but, Sublocade is kind of a safety, because it's good for a month. So I wanted to kind of see if anybody was using that and how that was working for them.
And I had started the Sublocade program at the clinic that I used to work at, and managed that for about a year until I left. And similarly, it has its pros and cons, and we had to decide with patients what their preference was, and decide who was the ideal candidate for the Sublocade injections. A lot of heavy lifting to get it ordered, to get all of that continued from the specialty pharmacies. And that's probably the biggest barrier that I found. It was that heavy lifting. It wasn't the prior auth. I got 6 months approved, no biggie. Same as someone who's on a higher dose that exceeds an insurance company's limitations for sublingual bupe. It was really the coordination with the specialty pharmacies, making sure it got shipped there, making sure it's in the refrigerator, all of those things. But we did that through ordering. I understand people could potentially explore buy and bill as well, but that wasn't a sustainable thing for our clinic financially, just because of reimbursement being too low for the expense of the medication itself. But I definitely had some challenges related to pain during the injection with individuals, and we not by the recommendation by the pharmaceutical company, but through anecdotal recommendations through other individuals, decided to start icing the site before administration, recommending someone take some Tylenol beforehand. That can help a little bit too. Other places have done topical or injectable lidocaine, which again, not recommended by the pharmaceutical company, but has been utilized kind of in an off-label-ish use to administer the medication. Does that help at all with some of my experience or answer your questions?
Maybe, Lynn, some of the people that we haven't heard from yet might have questions about the article itself.
Sorry, I forgot to unmute myself. I was saying, yes, I was been looking through the chat, and so far I haven't seen any questions, but this is a great time for somebody to ask a question or make a comment about their own experience. One of the things I wondered about when I read the article was what kind of impact their education on learning about the cows had on the culture. I could well imagine that there will be an increased comfort in terms of just working with the clients themselves. And that can certainly change the culture of an organization.
That's what the emergency department that we worked with said, that now they felt like they had a better handle on how to assess substance using patients coming through the door. And the fact that this was a objective scale that could be universally applied across all patients by all of the staff in a uniform manner, made them feel that that addiction was something that could be managed medically, instead of just feeling like, oh gosh, here comes that, repeat opioid using patient again. They started seeing that there is science behind how you assess and treat people with substance use disorders. They actually made comments like that in our project in the small emergency room that we worked with.
I could imagine it would take out some of the judgment, because I think sometimes the judgment comes from not knowing really what to do.
Mm-hmm. And not having confidence about how to work with those patients. So it's really kind of cool that this article documented improved confidence levels. And once they get confident in how to do the cows, they might feel more confident about learning something else new and becoming confident at that too. So that's one reason why I like this article.
Just wanted to have a little more information about the nurses. That not knowing what their training had been, not knowing what their experience had been, if these were new nurses or if these were nurses who had been previously working.
You talked about the ER nurses?
No, I'm talking about the nurses in this field who
Oh,
work
yeah.
in the outpatient clinic.
In this study.
Hi, my name is Vera. Can you guys hear me?
Yes, I can. Hi, Vera.
Hi. So my experience, when I became a nurse, I did med surg for 2 years before transferring to an inpatient psychiatric unit in a general hospital in Maryland. And that was one of the expectations for assessment, is that the nurses were to do COWS and CWAS and all those different types of scales on patients. But my experience is that there was no training offered at all. So I relied somewhat the same experience that Rachel had. I relied heavily on the senior nurses to to give me training, I guess, on the job training. But yeah, there was no like formal class or anything through the education and training department. We were just expected to know how to do it. And so, but it's a great tool. I really, I like the CWAT as well.
And to your point, I think the authors suggested that one change they might make is to keep it on a videotape or in some way make it so it can be run periodically as a refresher for nurses, perhaps have a low patient exposure, or for new people who come on board as well.
I tell you what would be a good thing is that we have to do, at least when I was working, we had to do health stream, like, you know, every year. Health stream. I don't know if you guys are familiar with the health stream program, but we had to do that everywhere. It's kind of like a built-in training program for the nurses at University of Maryland Medical System. And that would be a good platform where, you know, they give annual training on the different scales.
We were working on stuff like that until COVID hit. Now everybody's all hands on deck and we haven't been able to do fluffy kind of stuff. You know?
It's only fluffy when you're trying to get it started, but then it becomes incredibly important once it's all becomes an annual part of it, part of a larger annual training. So I like your idea, Sarah.
Because the nurses can do it on their own time, and they do it on their work computers, and it is known by their managers whether they've completed the trainings or not.
Exactly. Yeah.
So, hi everybody. I'm a nurse practitioner in addiction medicine at the University of Kentucky Medical Center. I only work inpatient. It's not a specific unit. We're a consulting service, so we cover patients on all the other services, so CT, surgery, medicine, ortho, and we address substance use from opiates, methamphetamine, alcohol, other stimulants, benzos, the whole gamut. But what I found interesting going through this article and then listening to this conversation has been the lack of formal education that nursing across the board has had, not only academically as preparing for nurses, but also on the job. And I find, you know, I do a lot of buprenorphine induction in the hospital because that's one of the primary medications that Medicaid pays for opiate use in Kentucky. They've since added methadone, but for a lot of our patients, it's too complicated to attend clinic every day, even if insurance is paying for it. So we do a lot of buprenorphine inductions. And so, you know, as I go through and I'm seeing these patients and talking to them about the induction, I also stop and have to make sure that I'm talking with the nurses and going through COWS scoring and what we need to be looking for and the importance of accurately scoring a patient on COWS so that we don't cause precipitated withdrawal as we go through the induction process.
Yeah, you know, I have I think that's so true. I have a DNP student that is doing her project on the educating nurses on COWS. And, you know, med-surg nurses, not, you know, they don't even know what withdrawal looks like. And that, you know, from the ER nurses do, but med-surg nurses don't. And they're, I think, kind of embarrassed to even admit it. And then also another problem is there's a policy at the hospital that the students doing, they have a policy and they have the COWS embedded in the score in the policy, which is great. But I was talking to the nurses and the issue is they call, they do the COWS, they call and there's no provider in-house to prescribe Suboxone. I'm like, oh my God, how frustrating that must be for them.
Wow.
Really
So
frustrating.
where is that at, Kathleen?
New Bedford, Massachusetts.
So they can't prescribe it inpatient despite not being waivered. They
They're not
can't.
wavered.
So
They're not
inpatient, they should be able to prescribe despite not being waivered as long as they're there inpatient. However, they can't give them a prescription to fill to go after they leave, after discharge. But inpatient, they should be able to. Any
Yeah.
No, but I don't know if that's true, Rachel. I think
Yeah.
they can prescribe buprenorphine to keep somebody from going into withdrawal, but I don't think they can do an induction to start somebody on treatment without a waiver.
Yeah, not in Massachusetts.
Huh?
Not in Massachusetts.
I think that might be a federal data 2000 kind of thing.
But also providers have
Depends if they got an addiction specialist. If it's an
No,
addiction
they don't.
specialist.
They don't.
They ought to have a consult service like Jessica has, and the addiction psychiatry should come over and do the induction.
The
Well,
problem
and
is when patients come in like that, you know, they're coming up from the ER and they're in withdrawal. It's not during 9 to 5. You know what I mean?
Right.
And that's really frustrating. So
and I do run into not just not having providers who are capable. I have a lot of, and this goes across the board with nurse practitioners, PAs, and physicians who just aren't comfortable with the medication themselves. So it's not that they can't do it, they're just not comfortable doing it. And so a lot of times it doesn't happen. And we see that in a lot of our smaller hospitals across the state, because we do have a lot of rural areas. And so, you know, one of the things we're trying to do is reach out to the smaller hospitals so we don't run into a situation like Kathleen's seeing.
It happens. It always it happens with methadone too, because the hospital can only give it to them for 3 days, and they have to come every day to get it in Ohio. They're trying to work on that now. Like, you know, sometimes they'll release them to go to a program like yours or mine or whatever. And they don't have it, you know, some of the programs don't take them. We'll take walk-ins immediately, but some places don't. And, you know, it's bad in hospitals that don't allow them to put them on Suboxone or methadone. It's not good. You know, sometimes they have to use Suboxone for pain or that type of situation. And, you know, but in Ohio, it's also kind of, you know, it's a struggle, but that's why it's good to have somebody that can do an addiction specialty there so that we don't have to go through that. So
the DNP project that we had, where we only did one induction, but we had 31 other people that got transferred to med-surg for medical problems. The first thing we did when we were developing the protocol was to get the emergency physicians to agree to hold the people in the ER until the psych clinic on the second floor opened up. And that meant like keep them in the ER instead of treating them and streeting them and giving them a card for where they can go get buprenorphine induction. They agreed that they would hold, if the patient agreed to start buprenorphine in the morning, we had first, the hospital agreed to keep them longer. And second, the clinic upstairs, the psych clinic, agreed that they would take them as soon as they could feasibly open in the morning and get them started, you know? So like the importance of appropriate referral relationships can't be understated. And, you know, we are kind of coming away from a discussion about the cows and more into a general discussion about buprenorphine, but I'm okay with that because I like talking about buprenorphine. But I think the nurses then were able to provide comfort care to the patients in the ER because they weren't rushing them out the door to make another bed available. They were kind of in a holding situation as long as it didn't require them to be over 24 hours, you know, like if it was on Saturday night and they had to wait till Monday morning. But if it was on Sunday, they would just keep them till Monday morning when the psych clinic opened up.
Jessica, what I wanted to ask you guys, what is the, I know we're on buprenorphine, but what is, you know, in the comfort meds, what do you think works the best? Rachel or Jessica, you guys may know that. I mean, we use different things, but I was just wondering if you guys had anything that's a miracle until you get them on it.
For me, it was all patient preference. Oftentimes they had an experience before. This wasn't their first experience of opioid withdrawal. So they could tell me, I liked the way trazodone helped me sleep, but I hated the way clonidine made me feel. So I really and I'm not a prescriber by any means, but when making those recommendations to the prescribers on my team, I would have those conversations with my patients.
Okay.
Yeah, and I second that because it is everyone's, well, we like to think everyone's withdrawal is the same. A lot of times it's not. I have patients who sometimes will have more GI symptoms with their withdrawal. And like Rachel said, this almost 99.999% of the time, this is not the first time they've had opiate withdrawal. Right. So they're able to give us pretty detailed information about their withdrawal syndrome and what we can do to help them with that.
But see, the traditional way of treating them is to say, oh gosh, all they want is opioids. And one thing that the CALS does is help the nurses focus in on which particular symptoms they're having so that they know which symptoms that can be treated. You know, like if they're standing orders for things for GI symptoms, then they see it not just being they only come here because they want opioids, you know, kind of issue. They feel bad. So how can we make them feel better? Like we're doing a study on stigma and we haven't written it up yet, but the practicing nurses have a whole lot of stigmatizing views about patients with opioid use disorders. And when they come in voicing complaints, they're like, oh gosh, he's trying to get opioids, you know. And instead, they're failing to form a therapeutic alliance. And so if you used the CALS as an opportunity to engage and connect with the client, yes, then you can provide help to them, which will make them trust you more. And then they'll be more likely to want to do things like go to treatment. You know, when they're feeling this sick and the only thing that makes them stop being sick is another a dose of opioid, you're not helping them with getting through this period that they're in. And I think at some of the hospitals that we work with, there's some standing orders for and treatment programs that do inductions. There's standing orders for treatment symptom relief based on what kind of symptoms they have, like over the counter or other medications that can be administered besides buprenorphine to keep them comfortable until they can be induced.
We only have 2 more minutes, so I just want to see if there's anybody who has any other questions. I want to make sure that we can try to answer or comments. I wanted to especially, I feel like I haven't said anything, Jessica, to you, and I want to just say I really appreciated your input. You provided an inpatient perspective that I really we hadn't discussed too much before. So thank you for that. And it looks like you're going back to work. I see your mask is back on.
Yeah, we run somewhere around an average of 50 patients that we see. So yeah, that's my next stop.
Thank you for sharing your lunch with us, and thanks to everybody. You too, Kathleen. I didn't get a chance to speak to you directly either, so I wanted to thank you for participating. I'm hoping that there's some way that you can get some folks to come and help you. It sounds like you're in a really tough spot there. So maybe you can get some wayward people in Massachusetts.
Yep, that's the goal.
It's a good.
They're there. They just have to, you know, they have to get their way. They'll do it. It's just the battle. Everyone knows the battle.
So thank you all. Thank you all for coming. Our next quarterly meeting for the Journal Club is on the 14th, April 14th. I don't know what the article will be at, but it's always the article that has the CE credits. So when you're reading the journal, you might keep us in mind. The website, the Insta website, has information on how to get the CE credit. So you can go there, you'll get a discount as being an Insta member as well. I also asked, Robert for information on how to see. This has been recorded. Gosh, I probably should have announced that in the beginning. I'm sorry that I didn't. But they are available on the website. You have to go to it's www.insta.org/publications/club for anybody who wants to review the conversation that we've had for this past hour. So feel free to share it with others, encourage them to watch it. And I thank you all. I hope to see you in April.
Thank you.
Dr. Ann Mitchell is on the call, the editor of the journal. I'd like to thank her for making this article available to the Journal Club, and maybe she can let the authors know how much we enjoyed talking about their article.
Absolutely. Thank you.
Thank you.
Thanks.
Bye-bye.
Bye-bye.